Hello everyone, and welcome to another mini anatomy and structure overview. We are going to be doing the hip and pelvis today in order to prepare you to talk about musculoskeletal disorders of the hip and pelvis. You may want to pull up the lecture outline notes. They'll be the first couple of pages of the disorders of the hip and pelvis outline, and there are also PowerPoint slides posted for you on Blackboard. So let's go ahead and get started. We're going to review all the joints that are around the hip and pelvis area. And so to start with, we'll look at the sacroiliac joint. And of course, as the name implies, it's the articulation between the sacrum, kind of the very bottom part of the spine, as that settles or fits into the ring of the pelvis, and particularly articulates here with the ilium. When you look at the posterior view here, without the posterior sacroiliac ligaments there, you can see a pretty good view of how the ilium and kind of fits in with the sacrum, or the sacrum nestles into the ilium. This is not a very mobile joint. It's a pretty fibrous joint, and it is stabilized by a lot of really strong ligaments. So you see the deep ligaments, the interosseous sacroiliac ligament, which of course interosseous, between bones. And then we have again the posterior, and then here we have the anterior sacroiliac ligaments. This is always a nice view to look at, this little side view. It shows you just this little, it's called auricular or ear-shaped surface, and that's really where that ilium is going to fit into on the side of the sacrum. So you can see that the area of the ilium, of course, is pretty large, and the area of the actual articulation is pretty small. So it doesn't take a lot of force to cause some disruptions through the SI joint, because you've got this big external moment arm here to create a lot of torque. We aren't going to revisit SI joint dysfunction too much, but because we did that with the low back. But remember, whenever we're looking at one joint, in this case we're going to be focusing on the hip today, we do have to look at the joints above and below, immediately above and below, to screen out for associated problems. Another view here of the SI joint, but we can move on to the lumbosacral joint. This is the articulation, of course, between L5 and the top of the sacrum, or S1. And you can see here from this sagittal plane view a nice visual of the lumbosacral angle. Do you remember the degrees, how many degrees the lumbosacral angle is? Very good. It's about 30 to 40 degrees. So the way we would measure that is, here's the straight horizontal, and then we would look at the angle down of between L5 and S1. And yeah, you could get your goniometer out and put it up on the screen if you want, but it looks like about 30 degrees to me. Here's an anterior view. You can see the very bottom of the anterior longitudinal ligament as it tapers down and terminates on the anterior part of the sacrum. And of course L5 sitting on S1. The next joint we'll review is the pubic symphysis. This is another very stable joint, not a lot of motion occurring. Of course, it's the two ends of the pubis coming together, and they're united by this big piece of fibrocartilage here. This is also a very stable joint, of course. This is one of the main joints that completes what we call the ring of the pelvis, and it's reinforced again by superior and inferior pubic ligaments. This is very similar to the SI joint in that its primary role is stability, but there are a few millimeters of motion, generally in the sagittal plane, forward and back, with reciprocal motions like walking or running. When we see patients with trauma to the pelvis, like in a car accident or a very severe fall, they can have disruptions of this joint, and that's very serious, and as you can imagine, very painful. But it's very difficult to repair the pubic symphysis or the intersection here, because it's primarily designed for stability, but it needs a little mobility. We're going to go on to the sacro-coccygeal joint, so bottom of the sacrum, and its articulation with the coccyx. So these, of course, are the inferior segments of the vertebral column. The sacrum is 5 segments, that's all fused. The coccyx is 4 fused segments. And so there's a little bit of an articulation that can occasionally move between the sacrum and the coccyx. And we can see subluxations and disruptions of this joint, like if somebody falls backwards onto their bottom, like they slip on the ice and they fall really hard. Sometimes during childbirth, this joint can be disrupted a little bit and can cause some subluxation. So we can see patients with pain there. Well, now to the big news of the day. We're going to be talking primarily about the hip joint or the acetabulo-femoral joint. And it's perfectly fine with me if we just say hip joint. When we do say that, it's not like the knee or the shoulder. Pretty much everybody's talking about this articulation here between the head of the femur and, of course, between the acetabulum. So if we look at our arthrokinematics to start with, we have a convex head of the femur fitting into a concave acetabulum. So our arthrokinematics are convex on concave. So let's try to remember what that means. So that would mean if the femur goes one way, which way does the head of the femur go? Right, it goes the other way or the opposite way. And that's very important for particularly when we're going to be talking about hip joint replacement, and we have to understand those arthrokinematics to prevent dislocation in the early phases of repair after that hip joint replacement. We have 3 degrees of freedom, and again here they're illustrating one of those degrees of freedom, which is rotation in the transverse or the horizontal plane. So we have medial or internal and then lateral or external rotation. So I don't have the other motions. Of course, we have flexion and extension in the sagittal plane and abduction in the frontal plane. This is an incredibly strong joint, though it is also very mobile. We will be drawing some contrasts between this and the glenohumeral joint in the upper extremity. So if we think about, we have here the pelvis into which the head of the femur fits. In the upper extremity, of course, we have the scapula into which the glenoid fossa fits. But from there, I think the comparisons kind of dwindle because you certainly remember that the glenohumeral joint is not inherently very stable. Even if we look back at this picture, you can see the head of the femur sits very deeply into the acetabulum. That's incredibly different from the glenohumeral joint, where the glenoid fossa is very, very shallow. Remember, in the shoulder as well, the head of the humerus, only about 1/3 of the head of the humerus actually articulates with the glenoid fossa at any one time. Here, of course, you can see that virtually the entire articular surface of the head of the femur is in contact with the acetabulum. Further, we know that in the glenohumeral joint, the ligaments are very thin and loose. Very different. Here we have very large, thick ligaments. These are considered the strongest ligaments in the body. So here's our joint capsule, and it's pretty much covering the perimeter around the acetabulum and then kind of the perimeter around the base of the neck of the femur. Kind of spans right between the trochanters, right above the intertrochanteric line. Then that capsule is further reinforced by 3 very strong capsular ligaments. The biggest and strongest ligament is the iliofemoral ligament. What's the other name for this one? We call it the Y ligament, and it's because the superior attachment is on the AIIS, and then it comes down and it splits a little bit. Part of it up more toward the greater trochanter, kind of inserts along that intertrochanteric line, part of it along the more distal or inferior portion of the intertrochanteric line going down to the lesser tubercle. And you can kind of see the little split here, so it does look like an upside down Y. The pubofemoral ligament blends in a lot with the iliofemoral ligament. Of course, it's coming from the pubis, as the name would suggest, so inferior ramus of the pubis, and coming over and blends in along that intertrochanteric line. And then finally, we have the ischiofemoral ligament, which is deep to both of those, and posterior as well. So it's along the posterior part of the acetabulum, and then it twists and comes forward. And so if you were looking from the front here, it would be deep but coming forward and kind of attaching like on the front here. So when we look at the motions that the ligaments limit, the iliofemoral ligament limits only extension. The other two ligaments limit extension as well, but in addition, the pubofemoral ligament limits abduction. What about the ischiofemoral ligament? What does that limit? Internal rotation. Good. So that makes our close packed position extension, abduction, internal rotation. Another thing we want to review is a little bit about just the structure and the bone configuration. So we want to look at, in the frontal plane, there's an angle between the head and the neck. This is another distinction or contrast between the humerus and the femur. The humerus has a very, very small anatomical neck. The femur has quite an elongated anatomical neck. So the trochanters are quite a bit of distance away from the head of the femur, whereas in the shoulder and in the humerus, the greater tubercle and the lesser tubercle are very, very close to the head of that humerus. So this gives us a long moment arm. We're going to be looking at the muscles in just a minute, and you'll see that it gives the muscles that attach over on the greater trochanter, hip abductors in particular, a very long moment arm. So it helps to improve their torque production. So this since the head is away from the femur, there's an angle in the frontal plane. So we would start our little fulcrum here, and then we'd go midline down the shaft, midline up through the head of the femur, and that gives us about 125 degrees. And you might remember back in kinesiology, you actually you measured this angle drawn down on paper, and then we also looked at some of the disarticulated skeletal femurs that we have. Actually, this picture here shows our close pack position, and we have, this is one of those really elegant illustrations from the Newman book. So it's complicated but elegant. So it's a superior view, and it's showing abduction, extension, this is the front, and then internal rotation. So this is showing how the capsule gets tight with those motions together. Here's probably a better picture of that angle, 125 degrees. So here's our 125 degree of normal angulation in the frontal plane. And then we have our favorite words, varus and valgus. So let's just see if we can remember the definition. Let's always start with valgus. I just think that's easier to picture. When we look at any joint or bony structure that's in valgus, what that means is if you're starting from the midpoint, and in this case that's not at the head but down here a little bit, that means that the shaft is angulated laterally or away. And so what we see here is that increases that 125 degree angle more than that. In this case, it's showing you a 140 degree angle. The definition of varus, of course, is then that the shaft of the femur would be angulated medially. And so that, of course, will decrease this 125 degree angle, and in this case they're showing 105 degrees. So here we have coxa vera, so coxa meaning hip, vera or varus, coxa valga or valgus. And then the other plane we look in to look at the structure of the femur is in the transverse plane. And you probably remember normally that the the head and the neck of the femur are oriented forward in relationship to the shaft of the femur by about 15 degrees. So we normally have about 15 degrees of anteversion at the femur. If we had more than that, that would be considered excessive anteversion. So here we see these little red dots are showing us optimal alignment within the acetabulum, between the head of the femur and the acetabulum. So here the dots are out of alignment, and so you still see the foot facing forward like you normally would. But we can see that the head of the femur is angulated quite a bit further forward from the shaft than normal. So what position would the foot take if we lined up these two little dots? Right, can you picture that if you lined up the dots, the foot would be angled in a little bit. So we do typically see that. Most people stand or want to be in a position where the head of the femur is sitting in about the correct spot in the acetabulum. And so what we see with people with excessive anteversion is they looked a little pigeon-toed, but it's actually coming from the angulation of the way the femur sits in the acetabulum. By contrast, on this bottom illustration, we see that the head of the femur is not twisted forward, or it's only twisted forward about 5 degrees, where the normal is, of course, 15. And again, this illustration is showing the foot facing just straight forward, and the dots are not lined up. So if we line the dots up, I'm sure you can see already that the foot would be facing out. So we see a lot of people walking around with their feet kind of out a little bit, and one of the things we would think about is that that could be coming from the hip, and they could be in a little bit of retroversion. That concludes our review of the bony structure and the joint structure at the hip. So we've looked at the sacroiliac joint, reviewed the lumbosacral joint and angle, looked at the pubic symphysis, really briefly touched on the sacrococcygeal joint, and of course spent most of our time on the hip joint, which is where our focus will be when we're looking at pathologies. What I'd like to do then is just do a quick overview of the muscles around the hip, and I've just gone ahead and divided these into by their muscle function. And we're going to start with the hip flexors. We have a lot of muscles that can contribute to hip flexion, but of course the biggest and strongest is the iliopsoas. We have dealt with this muscle extensively, especially when we were talking about function of the lumbar spine, because again, if you have a tight iliopsoas, that's going to have an impact on the motion of the lumbar spine. So iliopsoas, very broad attachments, and coming down, attaching to the lesser trochanter. Of course, basically it does hip flexion, or if we're standing, it would do anterior pelvic tilt, which of course is closed chain hip flexion. We have the TFL, or the tensor fascia lata, and coming off of the ASIS and the iliac crest, of course inserting into the iliotibial band, and that's actually extending all the way down to the knee. So of course many of these muscles have more than one action, and I'll talk about them all their actions as we go. Here's just a lateral view, shows a little bit better. The TFL muscle belly is up very, very high, quite proximal, close to the greater trochanter, and again a lot of its tension though is continuing down through the IT band. I don't have a picture of the rectus femoris, just part of the quadriceps mechanism. We'll review that anatomy when we do the knee. But of course, I'm sure you remember that the rectus femoris does cross the hip joint and attaches to the AIIS. Sartorius also comes off of the ASIS, shares an attachment with the TFL. Where the tensor fascia lata comes laterally, the sartorius courses medially all the way behind the knee and attaches onto the medial aspect of the tibia. We're going to see a couple other muscles that attach very close here on the medial aspect of the tibia. What's the name of this distal insertion where those 3 tendons insert? Right, the pes anserine. What does pes anserine mean? Goosefoot. Good. And again, we'll look at those more when we look at the knee. The pectineus we'll look at when we do the hip adductors, but first we're going to go to the hip abductors, ABD. And the big dog, of course, is the gluteus medius here, and the gluteus minimus is deep to that. And those two are, again, coming over, attaching on the greater trochanter. So those are our very powerful hip abductors. The tensor fascia lata that we looked at before can do hip abduction. Pectineus, maybe, or I'm sorry, piriformis a little bit, maybe. I know I don't even have that listed there. And of course, sartorius, we looked at that before. One of the things you want to remember with all these lower extremity muscles is that when we're looking at functional activities, we have to think not only what these muscles do in open chain, but what they do in closed chain. And of course, the hip abductors are incredibly important for stability in unilateral stance. So when we're normally standing here with bilateral stance, line of gravity coming through the center of the pelvis, there's really no muscle function in the frontal plane required to keep the pelvis stable. There's a little bit of force, about a third of the body weight force on in each of the joints. Remember the joint reaction force. But when we stand on one leg, all that changes. Of course, we've taken out this support, and so in order for the pelvis to stay level, since we're not propping it up from underneath, we have to pull on it from the top on the other side to keep it level. And the pulling occurs from those powerful hip abductors, primarily gluteus medius, but also with gluteus minimus assisting. So when we stand on one foot, it requires quite a forceful contraction of the hip abductors. That pulls the pelvis and the femur very strongly together, and so we end up increasing the joint reaction force at the hip joint by about 3.5 times. We're going to be looking a lot at the impact of weakness in the gluteus medius on joint reaction and on gait, in the cases of arthritis. So we're going to be looking a lot more at this. If this is a concept you don't quite remember, you really need to go back then and review the kinesiology notes. Dr. Newman, the author of your kinesiology study, is really one of the premier researchers in this area, and so his book has a lot of good background information and good explanation. So I'd refer you back to your kinesiology text if you need to review this. There's our little pectineus. We go to the hip adductors, and again, pectineus also has an anterior line of pull to the ML axis of the hip, so it can do flexion as well. Our other hip adductors, we have a lot of them. There's gracilis, very long and skinny, coming down. It's another one that attaches into the pes anserine. We have Adductor Longus illustrated here, and wherever there's a longus, there's a brevis. So here's our Adductor brevis, and this kind of shows a little bit better how they all blend together. And then behind everything is the Adductor magnus, or big one. So we have pectineus, Adductor brevis, Adductor longus, and then behind it all kind of the Adductor magnus, spanning that entire area. So you can really see with this amount of muscle bulk that the adductors are really very powerful. Again, you probably don't go around adducting your leg a lot in open chain, but very important muscle for gait and for running. You might remember one of the actions of the adductors as a group is to flex the femur from an extended position, and so we often do use that to pull that leg through during ambulation and during running. If we flip to the posterior view, we can see, of course, the gluteus maximus here. Major, this is really considered the prime mover for hip extension, very large bulky muscle, attaching along the lateral aspect of the sacrum, posterior part of the ilium, coming over, and again, it's got an attachment on the femur, the gluteal tuberosity, but also into the IT band. And you're going to see that this is a powerful external rotator as well as a hip extensor. I don't have a picture of the hamstrings, I apologize. Other hip extensor, of course, is the hamstrings, and we're going to look at those in a lot more detail when we do the knee. I want to go back and look again at this picture so that we can see the external rotators. I'll look at the internal rotators in a second. So as we said, gluteus maximus is an external rotator, and then we have the piriformis, and then we have all these little external rotators, which have the really fun names like gemellus superior and inferior, obturator internus and externus, and of course the quadratus femoris. So all these little, I mean, they look little, but they are kind of short, thick, powerful muscles. So we do have a lot of strong external rotators. Again, we don't walk around externally rotating an open chain, but when our foot is planted and we turn our body away, so you plant your right foot, you rotate your body to the left, or your trunk to the left, that's really external rotation. And so we do that kind of planting and rotating a lot, especially in sports activities. So these do need to have a lot of power. Our internal rotators, remember the adductors do a lot of internal rotation, as does the tensor fascia lata. So that's a review of our muscles. And I'm going to let you just look at this nice picture. This is a view of it's a grapeberry, grapevines in, I believe this is Sonoma County, so next door to Napa Valley. And this is right before what they call bud break, right before the buds of the grapes are going to open up and start flowering. I told them in Wisconsin bud break had a whole different meaning, but so I'll let you look at that, and let's just review real briefly as we wrap this up a couple of mechanical things. So I already mentioned before when we were talking about the iliopsoas that the iliopsoas can do open chain hip flexion, but it also can do anterior pelvic tilt and closed chain, and so anterior pelvic tilt is considered closed chain hip flexion. Similarly, of course, if you're posteriorly tilting the pelvis, then that would be the same as closed chain hip extension. And what muscles would do that? Right, primarily of course the hip extensors, primarily gluteus maximus. The other thing that we have to remember is that in open chain, we have a little bit different relationship. So if you can go ahead and stand up. So if you're standing up and then you flex your hip in open chain, if you have your hands on your pelvis, you should feel your pelvis posteriorly rotate. Let's see if we can remember why that would be. So you're flexing your hip, so you're activating the iliopsoas. That is shortening. What would be elongating? Right, hip extensors, particularly gluteus maximus. So the passive tension in the gluteus maximus is going to help to posteriorly rotate that pelvis. The reason that that's important is it prevents excessive shortening of the iliopsoas. What do we call excessive shortening? I hope you got it right. Active insufficiency. The iliopsoas is actively contracting, and so picture that the attachment site of the lesser trochanter is getting closer to the ilium and the lumbar spine. And so in order to kind of back away the pelvis through that passive tension of the gluteus maximus, posteriorly rotates and it maintains a good length tension relationship. Similarly, now keep standing, hands on your hips. Go ahead and do open chain hip extension. This time, the passive tension will be in the iliopsoas, and of course the active shortening is in the gluteus maximus. And so as the gluteal tuberosity is moving back toward the back of the pelvis and the sacrum, that muscle is getting shorter. The passive tension in the iliopsoas is going to anteriorly tilt the pelvis. That's going to, again, keep the attachment sites of the gluteus maximus away from each other and preserve length tension relationship. So this is going to be important consideration when we think about positioning people for doing exercise, because we don't want to put them in a position where we would be facilitating or creating active insufficiency. That's going to make it a lot less efficient for them to do exercise, and it's going to decrease the force production that they can create and will make their strengthening less effective. All right, this concludes our anatomy overview. I hope you found it helpful, and you'll be ready to roll when we start talking in class about osteoarthritis and the other musculoskeletal disorders and problems in the hip. All right, have a great day.